Hi, Dr. Garima here again, and we are continuing to solve the FPD questions from Rosensteil, and I'll discuss more about from where I have prepared these questions and which book this is. But let's just quickly finish solving these questions for the ADC written part 1 exam. I had a long day, so this is a short video, just covering 4 of the questions. Well, let's start. So last time we had finished 9 questions, and today we are going to do at least 4. Question number 10. A patient with high aesthetic demands requires anterior restorations. Which material is preferred for best aesthetics? Best aesthetics. It's an anterior region. Basically, when you smile, everybody's going to see you smile, right? So you want something which looks very natural. Full metal is not an option. PFM. Porcelain fused to metal used to be done earlier when all ceramic crowns were not that much available. And the only thing that you were taught and the labs had was metal onto which porcelain was layered and compacted. But with the advent of the monoblock zirconia and lithium disilicate crowns with superior aesthetics and lesser preparation of the tooth, because even thin material can withstand a lot of pressure, all ceramic lithium disilicate is the option of choice. Now acrylic is also fully like white as in the natural tooth color, but it's not that strong. It will get abraded very fast when it's going to come in contact with the opposing natural teeth, which can be lower or the upper. So acrylic can be given on a temporary basis, or it has to oppose an acrylic teeth itself. It cannot oppose a natural tooth, like I mentioned, because of high abrasiveness. So the answer goes with all ceramic lithium disilicate crown for a long-term duration for best aesthetics. Okay. Now, what is the main determinant? I think I should use a mic. Yeah. Great. So what is the main determinant of path of insertion in an FPD design? Main determinant of path of insertion. Path of insertion is always related to the abutment. Always, always, always. Okay. It is not related to the material, that is the crown material that you're putting in. Path of insertion is always on the abutment tooth. So whenever any question is asking about the main determinant of path of insertion, it's always how you draw your abutment tooth. Draw means prepare your abutment tooth. It has to be straight. You should not deviate more than a certain degree. I think that is probably 7 or 10 degrees. You should not deviate more than that. The more straighter it is, the better is your resistance form for the crown, correct? So if one mesial side is straight and the distal side is at this angle, your crown is not going to go properly, correct? So if both the things are straight, then you'll have the best fitting of the crown. So if you have 2-3 abutments that you have prepared, then all the abutments have to be prepared in a straight line. That is called as a common draw of abutments, or the determinant of path of insertion. Now, which Pontic design is easiest to clean and preferred for posterior regions? Easiest to clean and for posterior region. Now, both of these factors you have to put in the filter to get your answer. If the same question would have been asked easiest to clean but for anterior region and with the same options, your answer would be different, right? So when you say easiest to clean for the posterior region, the answer becomes a hygienic Pontic. I'll show you what a hygienic Pontic looks like. This is how a hygienic Pontic looks like. You have plenty of space between this Pontic. Pontic basically is the tooth which you are going to put, the artificial tooth which you are going to put in place of a missing tooth, which is attached with the help of a connector to the adjacent teeth, which you have prepared, on which also crown is going to go, correct? So this is the mucosa, and there is a huge gap between the crown and the mucosa, basically the Pontic and the mucosa, and you can easily clean this. Now, you cannot give this in the anterior region because it won't be aesthetic, correct? But can you give this in the posterior region? Yes. Now, if the same question would have asked you which Pontic design is easiest to clean but in anterior region, then you would have gone with modified ridge lap. If the question would have asked which is the Pontic design which is the most aesthetic of all, then the answer would be a ovate Pontic. Ovate Pontic is the one which kind of emerges from the gingiva. It goes in that depression of the extraction site. So it seems as if the tooth is coming out of the gingiva like a natural tooth. But that is not exactly easy to clean. It kind of impinges on the gums and it can cause inflammation of the gums, correct? So for temporary basis, you can give in an anterior region, but then ultimately you'll have to go with a modified ridge lab. So I hope you have understood this. I want you to pause this video, go ahead and see all different types of pontics. Go see their designs, go see in which condition you give them, correct? Now we come on to which question? Yeah, question number 13 and the last question for today, and a very important question. This can be asked in your exam at any given point of time, and you should also be aware of this in your clinical preparation when you're doing an FPD, because this is such an important point to remember to maintain the longevity of your restoration and the patient comfort. What is the biological width that must be preserved during crown preparation? What is a biological width? Biological width is nothing but the bone asking you to maintain a distance. U means the crown margin, okay? I've got a very nice picture and I will show you here. Where is that picture? Yep, this one. You see this? So basically a flap has been raised here to show you the biological width. Now this is the margin of the crown. This is the bone, and intentionally drilling has been done to push this bone a little more apical so that there is distance. There is a safe distance between the margin of the crown, that's the artificial material, and this bone. Okay, now this distance is called as biological width. Basically, in very simple terms, the bone is telling you to maintain a distance of 2 mm from itself, as simple as that. Now, what if you don't maintain the biological width? Basically, if this is your crown margin and it is very close to the bone, say less than 2 mm, then what is going to happen? The bone is going to go mad, it's going to get angry, and because it will get angry, it's going to become red. Basically, the gingival inflammation is going to set in, and then the bone loss will happen, which would be a pathological bone loss, resulting in a pocket formation. So basically the bone is telling you, maintain distance from me. If you try to come closer to me, I will get mad, I will make the gingiva inflamed, and then a pocket is going to form, which is going to lead further bone loss and hell lot of problems on your end, because you have given a crown and the patient is going to come back and say, doctor, my gums hurt, my gums bleed, what am I going to do? And then eventually you will have to raise the flap, reduce the bone, or you have to remove the crown or do something about it, you know. So in cases when you have to do clinical elongation of the length of the crown because the margin is short, because either it was fractured or there was caries, then you will have to do a crown lengthening procedure properly. Basically, you'll have to reflect the gums, push the bone away by drilling it manually, but that's a healthy bone drilling. So no pathological inflammation is gonna set in because you're reducing the bone intentionally, so as to give that space between the bone and the margin of your crown. That's called as biological width. Remember this analogy of bone getting angry and becoming red and inflammation setting it because the crown margin did not give its 2 mm of space. Understood? So I hope you will remember biological width with this. And from where am I putting these questions? From Rosensteil. Rosensteil is the FPD book, which is recommended by ADC. Your written exam syllabus is vast. Not necessarily the books that you have studied in your dental graduation are the books from which the ADC is going to ask questions, but ADC has been generous enough to give you the sources from which it's asking questions. So it obviously becomes common sense to study only from those sources, and those are many sources. Like we have 21 topics, and there are in all 25 to 30 books from which ADC is taking, books and articles, I would say all combined, from which ADC is taking their questions and asking you in the exam. So I've given you the topics out here. Apart from this, there are 7 other stuff which I have made the comprehensive book about, which is Therapeutic Guidelines, Odell, Infection Control, Ethics, etc. And these are the rest remaining 21 subjects. So I have taken those textbooks and articles mentioned on the ADC website, and from them I have made the SBQs, and this book is around 583 pages, meaning I have more than 1,400 SBQs proper with questions, answers and explanations. So if anybody wants to buy this book, I would say this is the ultimate companion. As mentioned in my last video, you can either do the hard work of taking the staircase to reach your destination, or you can take an elevator, because your job actually starts after reaching the destination. So why waste so much of time taking the stairs when you can take the escalator, and this is your escalator. So if you want this book, you can email me on adcwrittenmocktest@gmail.com, or you can see the description below for more information. And I've uploaded a sample copy of this book on my Target ADC Facebook group. You can even access it from there. And have a nice day. I had a very long day. It was a nice day, but a very long day. And I'll go to sleep now. Good night. Bye-bye.